Okay, good evening, everyone. My name is Charlotte Garner, and I'd like to welcome you to the National Consumer Advisory Board, the Ellen Dailey Advocacy Committee's fourth installment of Community Conversations, where today's topic is harm reduction and HIV. We would like to say welcome to each and every one of you, and we thank you for being here on today. Today is a really special day because we have two very special consumers who will be presenting on today. But before we get ahead of ourselves, let's go ahead on and take care of our event etiquette. For this, we are asking Myra Nagy if she would please read to us the event etiquette for this event.
Awesome. Give me just a minute to bring it up because I wasn't aware I was going to read it. Let me see. It is right here. It says, event etiquette, respect the speaker. Please behave in a courteous and respectful manner at all times. Respect yourself. Appropriate attire and grooming is required. Respect the group. Remain muted unless otherwise directed. No moving backgrounds. If you have to move during the presentation, please turn your video feed off. Refrain from interruptions. Please use the raise hand function from reactions or raise your hand on the screen and wait to be called before unmuting. Respect the time. Please limit your questions to one at a time to give everyone a chance to participate. Q&A is designated to take place at the end of the event unless otherwise facilitated by the presenter. Remember, the speakers sacrifice their time to share important information to benefit the needs of others. Feel free to express your gratitude. I'm gonna say both. Thank you.
Thank you, Myra. And without further ado, I would like to introduce our first speaker of the evening. We're very pleased to present to you and to introduce to others who have not met her, Miss Amanda Richard. Amanda is a displacement consultant of the One Health Program Manager for Donnie Co Pet Clinic, which provides veterinary care and human health care through a Healthier Here Institute. In addition, she's vice chair of the Governor's Council for the Healthcare Network for the Homeless in Seattle and Kings County. She also is the community liaison for the Department of Neighborhoods of the City of Seattle, working for those experiencing homelessness. In addition, she serves as development lead for the resource app, Shelter App. She also serves on several boards and advocates and speaks nationally on issues surrounding homelessness. She is an artist and a photographer as well. Her passion for human rights and societal healing comes from her personal experience with many traumas and experiences, including chronic homelessness and systemic abuses. I present to some and introduce to others, Miss Amanda Richard.
Thank you so much, Charlotte. I appreciate that introduction. I'm going to begin and just share my screen here. Okay. So let's talk harm reduction and community engagement. This is a topic that I'm really excited about and passionate about because it takes the me out of the equation, and I'm going to explain that in a little more depth. So first, when we go into harm reduction, we're going to overcome some personal judgments. So you're going to hear, I think people shouldn't use illicit drugs. I think people shouldn't have unprotected sex. I think people shouldn't participate in activities that are unsafe. All of these statements are personal judgments based on opinion. And much of our opinions and our beliefs come from the environment which we're exposed to. And that includes systemic biases and racism. We use a pragmatic approach. People use illicit drugs. People have unprotected sex, and people participate in activities that are unsafe. Removing personal feelings and opinions. It is not helpful, or is it effective to impart our personal ethics or morality onto others. Meeting people where they are at. What does this mean? So meeting people where they're at, and you're going to hear this term a lot, it means to accept and honor their humanity where they are physically, mentally, and emotionally, without the expectation of them changing to meet your needs or wants. To start the conversation, when you're approaching an individual that you know could benefit from knowledge on how to reduce harm from their actions or behaviors or others, you're going to connect with them with empathy, acceptance, and compassion. You're going to recognize their humanity. You're going to start the conversation as you would anyone else. Hi, how are you? You're wanting to connect with them. You're not wanting to judge, shame, or blame them. When you connect with them and they start talking, you're going to listen without adding your own spin on their situation. Every experience is different. Every person has an ocean of all of these experiences and interconnected issues that we can't see from just a first cursory glance. And we need to respect that. Engage them in ways of thinking to utilize harm reduction. So when you're talking to somebody, I think you should do this, is not where we want to be. Where we want to be is, okay, well, if they mention that they use substances, well, have you heard about, I hear that ODs are really high. Have you heard about fentanyl chest strips? Hey, do you carry Narcan? Narcan is a good way to start the conversation. Asking if they have supplies or needs. Bringing those resources to them and accepting them for having the issues that they have or that they're struggling with. That's where we offer resource supplies or ways. So when we're approaching somebody who uses substances, there's so many ways that we can promote, don't use alone. Hey, Narcan will save your life. Are you having trouble finding clean needles? If so, let me help you. Let me send you somewhere. Because the issue is we're trying to reduce the harm. We're not addressing whether they should or shouldn't be engaging in the behavior. We just want them to live in a safer manner. Understand that they may not be interested, and that is okay. Every point of contact is important. You want to accept the person and their story, whether they are interested in harm reduction or not. You don't know if you are planting that seed that will then grow into thinking about ways that they might want to change behavior to become less harmful. Why harm reduction? So harm reduction, even though it's becoming more to the forefront now, it's been used for thousands of years to address public health issues, and it is more effective than judgment about what should or shouldn't be. Some examples of historical harm reduction are housing, of course. So in ancient times, they knew, city planners, that to have business, to have an economy, to have a thriving city, you had to house your citizens, you had to house your workers. Housing has always historically been harm reduction. Papyrus Ebers, that is one of the first mentions of contraception, and that was through Egypt. Roman architecture, aqueducts, public toilets, garbage removal. Sanitation services are really important, as we have learned throughout history with virulent illnesses and water issues. Speed limits, vehicle standards, seatbelts, airbags. It's very easy to tell people you should wear a seatbelt, but when it comes down to it, we need to instill regulations that say, hey, this has become a public health crisis. Safety equipments, life jackets, hard hats, hunter's orange. People started getting shot by accident by their fellow hunters. It was a problem. So what did we do? We came up with a system of wearing a color that would identify you in the woods so you didn't get shot by your uncle or, friend. Sorry, attempted humor. So what are harm reduction tools that we can use and resources? So some of the things that we use right now are providing safe and regulated community places for use. We've done this for a long time. Some of those are bars, smoking areas, and safe consumption sites. Now, we don't have as many safe consumption sites for illicit drugs as the other because we are still caught in technically the war on drugs and prohibition. But as we know from history, that drug use and substance use has been around for thousands of years, and its acceptability and whether it's been part of religious ceremonies and other things has waned and gone throughout society. So the best way is to provide a space with a safe and regulated supply. Providing, this comes down to number 2, providing safe ways to consume this substance. We do this again. Portion control. Have you ever wondered why they pour it into a shot glass, alcohol into a shot glass before presenting it to you? The reason for that is because that way you know how much you are consuming and you can regulate your use. Substance testing, that is really important. Knowing what you are, for example, in Washington, we have a safe and regulated supply of marijuana. When you go into the store, you can look at the back and you can see who grew this. Did they use pesticides? After it was grown, which lab did they send it to? What were the results of what is in there? So I know what I'm consuming, and again, portion control, how much I'm consuming. Clean and sanitary tools for use. Again, we do this very often. Washing dishes would be one of them. But that can also be providing, again, clean needles, supplies, so that people are doing things in a way that's promoting health. Even if a behavior is engaged in, they can still promote a healthier way of being by taking little steps. And these are really life-saving supplies when we look at it. Hepatitis, for example. Hepatitis can be spread very easily, actually. And when we're looking at using life-saving supplies to stop the spread of some of these things, that's a public health issue. Because contrary to popular belief, our behaviors don't stop at us. Our behaviors go out and they continue to affect the people that we live, work, and reside with. Education based on evidence, not opinion. Again, removing the you from the equation. That is, I don't know how to say how important that is, and how important it is to educate others and our communities and our people about harm reduction, ways to reduce harm, so that we can all live in a healthier state, healthier community. Education and inclusion in communities. People who use substances are community members. They are parts of our community. They are not others. By including people who have lived experience or who are experiencing these behaviors, these actions, they should be involved in the community planning. It's hard to educate a community when all they've heard is opinion, bias, and stereotype coming from the systems in charge. So by getting, and I'm sure all of you know, that when you get to know somebody and you get to touch that ocean underneath, you start to be able to understand. You start to be able to see the interconnectedness and realize that most people fall in a multitude of categories, and there are a multitude of reasons. So reduce the stigma, accept people where they are for who they are. Engaging our leaders, again, educating our leadership, our cities, our towns on the truth behind the drug war, which is, I've done another presentation and gone through how exactly our criminal justice system turned racism into a blatant attack on communities through the drug war. Provision of inclusive activities. When you have a harm reduction event and you're giving safe use supplies, when you're engaging people, when you're talking to them, when you're feeding people, when you're doing anything, engage everybody. Ask people to come. Don't fill them with fear and say, oh, it'll be safe. Come and enjoy our community. These are not really worries that you have to have. And I think sometimes that we can spark fear in volunteers by engaging on that level. Peer support, that is huge. Having people with lived experience, as we all know, having people who have gone through a situation lends to understanding not only with the people that we're serving, but ourselves as well. Every time that I engage someone, every time that I talk to somebody and remove myself, I learn a little more. I am better able to connect with people. I'm better able to listen. And I do have to check myself and remind myself often, it's not about me. It's not about me. It's about healing. And providing those who use with opportunities to thrive. We know that regardless of any behavior, our community members should be healthy or access to ways to be healthy, and not just to survive, not just the bare minimum, but opportunities to thrive regardless of where they're at. That means employment opportunities that can be for people who are who are still using. That means acceptance of housing for those that are also still using. That includes low barrier supports and resources. And that requires us dropping our biases and stigmas and stereotypes and consistently questioning ourselves about how those biases enter into the work that we do and how we can reduce harm in the ways that we reach out to each other. For optimal success of any harm reduction strategy, human rights must be achieved. That's regular access to clean water, that's nutritious food, that's safe housing, and that's equitable access to healthcare. When those systems are in place and those basic human rights are achieved, our communities will become healthier and they will be better able to support each other in these goals. Thank you.
Thank you so much, Amanda, for that wonderful presentation. We'll ask now that if you would be so kind as to hold your questions. If you feel like you're going to forget them, write them down or put them in the chat. I'm going to defer now to Valerie so that she can introduce our next speaker. Again, let's give a round of applause to Amanda Richards.
Thank you, Amanda. And you know what? I'm not going to introduce Joanne. I'm just going to make a suggestion. Everybody give one word that represents Joanne.
Passionate. You're not going to do
Yes.
that to me.
I'm Joanne.
All right,
Joanne.
all right.
Okay.
Amazing.
Cheryl, go ahead. Go ahead.
Driven. Deidre.
Paul.
Loving, kind, compassionate.
Go park your car.
So, and that's who Joanne is. And in the chat, we see compassionate. Barbara says spirited, knowledgeable,
Well-
and that's who Joanne is. And that's the work that she brings to Boston Healthcare for the Homeless program. And also she was a member of the NCAF Steering Committee and she does amazing work. And I'm just so glad she's back walking and back on her feet. But I'm not going to talk about her. I'm going to let her talk about her. Joanne, thank you.
All right, listen, I'm calling Jim because he's only got like 15 minutes. So I'm gonna see if he wants to come on now and then I'll talk after Jim, all right?
Hey, Joanne.
Jim, do you want to get on right now and talk?
Sure.
All right,
Happy to.
thank you. All right,
Okay.
bye. So I'm gonna have Jim get on now because he's only got so many minutes. And then if I start talking, we all know how I talk a lot. So let me just let him do his thing and then I'll get on after him. Is that all right, Val?
And Joanne, it's your show.
All right, then, all right, you got it. He's getting on any minute. Let's see him get on. Valerie, you look so pretty.
Why, thank you, Joanne. Where's your face?
Let's hide.
Why?
Because it looks ugly.
So let me just tell you all, Joanne has been away from the work for about 3 years, and she had an operation on her hip, and she's walking. And I'm happy.
Seven
She's
weeks
walking
in the
again.
hospital.
Yeah.
Imagine, that's like a lifetime. I don't know if he's on yet. I can't tell.
So why don't you start until he gets here, and he can always jump
Yeah, but
in.
he won't cut. He won't cut in. So
I'll
Jim,
make sure he gets in.
Jim,
There he is.
There
Oh, there he is.
Okay.
Yeah, I was just going to see what we needed to do, but I just saw his name pop up. Jim, can you hear us? Yep, there he is.
Hey, Jim.
Where's he
There
at?
he is.
Hello, everybody. I just missed everything that went up until right now, but hello to everybody. How are you?
Jim just moved to his new house. So, hi, Jim.
Yeah, I don't know if you can see all the boxes behind you. I'll show you. There's just full of boxes all over the place.
Oh,
but,
that's all right. That's all
we'll
right.
get there
That's how my
eventually.
house- That's what my house looks right now.
Right.
So we had Dr. Jim O'Connell from Boston Healthcare for the Homeless. Joanne, you want to introduce him
Yeah,
and what you want him to talk about?
I want him to talk about the SPOT program, harm reduction. Jesse couldn't come, Jim, but I thought maybe you could kind of share a little bit about harm reduction in our program.
Sure, I'd be happy to. And I'm so sorry Jesse isn't here. As you guys probably know well, that Jesse's like one of the more amazing people in the world, Jesse Gator, and she's been our chief medical officer for the last many years and is completely immersed now in addiction medicine and harm reduction and ways to improve and prevent, at least ways to prevent opiate overdose and drug overdose. But it's a long story. Harm reduction is a long story, and most of us have had to come to harm reduction the long way, not the short way. And I think if I could, the easiest way for me to say it, and stop me at any time if you think there's stuff you want to ask me about. But when I first got into the world of substance use disorders, it was as the medical director. I was working for the Healthcare for the Homeless program, as I've been doing all along, but we weren't making enough money to pay our rent. So we would get our doctors and nurses to have sort of outside jobs. And mine was to be the medical director for a methadone clinic back in 1986 or something like that. And also of the state's first dual diagnosis detox program. And I knew nothing coming out of medical school and residency about how to take care of substance use disorders. And I knew literally nothing about methadone. What I did know about was AA. I had been taught about AA, and we understood the strict and beauty of AA, where people get clean and sober, and it's a day at a time, almost a spiritual commitment to doing it. And it's quite remarkable. But what was also very clear to everyone at AA is that it wasn't for everyone. You know, if when AA looked hard at everybody coming to AA, only about a third of people were still clean and sober about 5 years later. So there was still need for more, more therapies, more ways to look at this. And so what used to be a pretty strict, we could treat people with alcohol, detox, for example, you could do the detox, but people who were struggling with opiates were really poorly treated. They were not given, they were given sort of comfort medications, but nothing that really helped with withdrawal. And the traditional detox programs and early recovery programs demanded abstinence. They meant if you really want to come in, we have to get you off whatever you've been using and you have to stay clean and sober. And while that was great for the people that it worked for, it clearly was not enough. And so methadone came in, and as you guys probably know, methadone came in, it's a synthetic drug. It's made in the laboratory or in the factories. And it's a really strong opiate that substitutes for, let me try to shut my phone off, which I should have done before I started. I'm so sorry, you guys. But it was something when you take methadone, it sits on the receptors that heroin goes to and blocks heroin from acting. And it was for the early times, it seemed like a miracle because many people who just struggled like crazy could never get rid of the cravings and always relapsed. And they had these remarkable results from methadone where easily 90% of everybody who got on methadone was able to stay clean, get a job again, get back into the program. The problem was that the federal government decided, as you know this, you could argue that the entire approach to substance use disorders by our government has been kind of racist, and it has been kind of punitive. So the methadone clinics were the only people that were allowed to give methadone were these clinics, usually in an inner city where 80, 100, 300, 400 people had to come every day and get their dose. And you couldn't get it from your doctor's office. Like to this day, I cannot prescribe methadone for you if you have cravings and want to get off or cope with your recovery from opiates. You have to go to these clinics where it brings everybody together about the same time every day. And these clinics get a terrible name because if you were going to sell drugs or something, you would go down where these 300 people were gathering, all of whom were vulnerable and fragile, and you'd kind of entice them. That's where and so methadone kind of got a bad name as it has today, even though from a strictly healthcare point of view, medical point of view, it's the most effective drug we have for almost anything. It's far better than insulin is for diabetes. It's really effective. It's just that it's got this pejorative sense to it. That was methadone. And I had to learn that. I didn't learn anything about it. And I was stunned when I would see these people coming in, who are lawyers and doctors and, really, had real lives going on. They came every day for their methadone alongside people who were struggling to survive on the streets. So I got to realize that methadone was very effective and we shouldn't be so hard on it. Leave that aside. I see that Barbara's here and Barbara can help me on how the rules around, the federal rules around methadone make it the strictest of almost any medication we have, even though it's probably one of the safer drugs. So anyway, that was the beginning of saying, can you get on something that wasn't pure abstinence? It was something that you could take every day, sort of like you take your blood pressure pills or you take your diabetic medicines, and it would help with your cravings and help keep you sober. And the people in AA had a very difficult time with that because they thought that was just another, you were substituting one addiction with another addiction. And there's a lot to that, but I think what people began to realize that if you just looked at it as medication for an illness, as opposed to putting it out into, it was really effective. And then as you may know, buprenorphine, which is Suboxone or Subutex, came along, many years later as an effort to try to get some of these medications into offices so people don't have to go to these big clinics where they were gathering, gatherings of lots and lots of stuff. So buprenorphine came around, I'm guessing now about 20 years ago, 15 or 20 years ago. And they were very skeptical of it at first. A doctor could only have 20 people and then 30 people that you could give it to and then no more. But you could do it in the office and you could, it became much more in the healthcare system as opposed to in the punitive semi-legal system. But that began to open up things a little bit more. Now, all that said, so when you hear about medication-assisted treatment for substance use disorders, that means you would take primarily, there's many different ones now, but it's primarily methadone for opioid use disorder and or Suboxone. And there's a lot we could talk about why they're different. But if you extend that and start to say, okay, and this is what happened to us. And if Jessie were here, she would give you, the blow by blow. But what we were finding in our healthcare for the homeless main clinic down at right across from Boston Medical Center, we were finding that people were coming in highly sedated and passing out in the waiting room. We had set up these really nice private bathrooms when we opened our new building. But in those private bathrooms, we were having a number of overdoses every day because it was one of the few places people had where they could have privacy. And then we were stuck with this dilemma about what do we do? Do you get punitive and kick everybody out, or you try to engage them in treatment? Whatever, And so Joanne can tell you this, one of the brilliant ideas that someone had, and I think Jessie ran with it, was we had this electrician who was an MIT grad who suggested that we get this, what they call a reverse motion detector. And what it did was, since people could be in the bathroom long enough to die, and by the time we got in there, they were already dead. This was something that if you went into the bathroom, if there was no motion, and initially it was for 3 minutes, and we had to get it down to like 2 minutes and 12 seconds, there was no motion in that time, a bell would ring and each person would know we'd be coming in to make sure you're okay. I laugh about this because the first time I went running in when there was an alarm went off, this poor guy was sitting on the toilet reading a newspaper, perfectly okay, but scared to death when we came in. But since then, everybody is grateful for that because they know if anything happens to the bathroom, someone's going to come before they die. And we've had virtually no deaths by overdose in that setting. And then the second thing that was happening is, what do you do about the people who have just used something, they're feeling sedated and they're frightened, are they going to overdose or not? And so Jessie and several of the nurses and other doctors in our program decided to take our common room, which is right off the main lobby, and set up cardiac chairs, these chairs you can sit in and be monitored like if you've ever been in the hospital for, where people could come in voluntarily because they've just used something or they're feeling oversedated, or friends can bring people in. And we can put blood pressure cuffs on them and measure their oxygen and monitor them for the next several hours. And Jessie's name for that was a supportive place for observation and treatment. And it was amazing. It was, people would come in, we got to engage people, lots of people from there would go on to treatment, but they knew it was a safe place to come in and nobody's going to ask you any questions. It's anonymous if you want to be anonymous, or you can engage in care. And if anything was going on, we had our full clinic right upstairs, right next to it. And I might have been a little skeptical at first because I thought it might be too chaotic, but it turned out to be one of the most brilliant things I've seen done. Now, that's harm reduction. That's saying we're not going to make you stop. We're going to try to take care of you. And as Joanne once said, and Joanne, you don't mind me quoting, that we're trying to engage people in treatment, but you can't engage dead people in treatment. So we were trying to prevent death and give people an opportunity to say, there's hope for tomorrow. Let's move on. We ran into a lot of trouble, as many of you may know from all across the country, where there's also a thought about, should we be supervising when people inject? Should we be, because what has been shown in several countries, if you have nurses and people who know how to inject and take care of people, you can do that in front of someone. Somebody's there to monitor you. So if you had too much, that you're right there, but you don't get infections, you don't get the abscesses that you're talking about, and you don't have overdoses. And those are called safe injection facilities. SIFs, S-I-Fs, if you've been hearing about that. And that's where a lot of the controversy is right now, because that's taking harm reduction to another end. You're saying, we're not here to make you get clean or stay clean and sober. We're here to make sure you're safe and can live to the next day and you don't die of an overdose. Can you see that? So there's two different approaches to that. And we could go, the other extension of harm reduction is to make sure people have clean needles, to make sure they have clean pipes, make sure they have the works that they don't have to share, so they're not passing AIDS or hepatitis C from one to another. And all of that all falls under the rubric of harm reduction. And why don't I stop there and be sure there aren't any questions, because I'm going a little bit too fast. So please interrupt me if you want. This is a long journey for us because we're trying to figure out where we are. And don't feel badly if you are leaning on one side or another. I think that's the conversation needs to be, what should we do? I just saw Warren there. Warren, how are you tonight?
What's your name? Who had a question or an answer? Was it,
Oh, I'm sorry, I didn't even look in the chat.
no, I'm trying to figure, I don't remember who it was. Who was it? Who said they had something funny to say?
Barbara.
Oh, Barbara.
Oh, okay. So I just wanted, hello, Jim.
Hey, Barbara.
So Jim so beautifully talked about the methadone clinic piece. What's really interesting is at the time, buprenorphine, so this is like 20 years ago, buprenorphine could only be in a methadone clinic. And so 20 years ago, in order to get buprenorphine into primary care clinics like ours, so that physicians like Jim can actually participate in medication-assisted treatment and prescribe, in order to get that out, the federal government put into place this onerous set of regulations that govern how that treatment gets done, to the point where it's such a pain in the ass that a lot of physicians just don't do it. And that's why it's really hard to get buprenorphine. And so the access is so hard. This is why so many people have to buy it on the street first. We are advocating in Congress right now to be able to get rid of those regulations so that it's a lot easier for physicians like Jim to prescribe this, just like any other drug that he would prescribe, without all of this, frankly, regulatory red tape that's put on it. And so in our advocacy, we had to lobby the Biden administration, because if Congress passes this, the Biden administration needs to sign off on it. Here's the thing. 20 years ago, when these regulations were created, who was the lead sponsor of the fight in Congress to make those regulations happen? It was Senator Joe Biden from Delaware. Senator, so now 20 years later, he's president. And now we literally have to ask him, hey, dude, we can do this better now, but what you staked your hat on, we need you to kind of overturn. And that's a super awkward conversation to have with a politician, to ask them to like go back on what you did 20 years ago that you fight so hard for, because then he would be labeled a flip-flopper, right? Can you see how that would play? So all of a sudden they would use it against him. So we've really had to argue with not only the Biden administration, but now we're in Congress trying to get those rules overturned. Anyway, so I just wanted to share that fun little history fact with you, that 20 years ago, the stuff that happened is following us to this day. And we're still trying to battle to make it more easily accessible and to reduce the harms of people in opioid use disorder. So that's just what I wanted to add as a PS to Jim's fantastic history thing.
Barbara, you're perfect. I'm going to add to, you're just ringing all these bells for me. But so just so you know, if I want to become a buprenorphine prescriber, I have to spend 4 to 8 hours in special training, and then I have to apply for a special extra sort of DEA number. And then when I get that, initially I was allowed then to only prescribe for 30 people. Now it's much of this is relaxed thanks to the effort of Barbara and everyone else now, but it's still amazing to me. I can prescribe without any training the worst chemotherapy, the deadliest chemotherapy, hard things. But if I want to give you some safe buprenorphine, I have to have 8 hours of training.
Hey, Jim, let me ask a question. So what is the difference between the drugs, between what you're talking about and Vivitrol, or the drugs they're giving out now? What's the difference?
That's a great question, Valerie, and good to see you, by the way. Thank you for inviting me. The way I think of it, to be simplistic about it, so methadone and buprenorphine, as they are, have to be given every day. Methadone once a day, buprenorphine is usually 2 or 3 times a day. So you have to take them all the time, right? But the longer acting ones, like Vivitrol, and then we also have another one where buprenorphine comes in a long acting thing, you can get once a month with a shot. And then you don't have to worry about your daily stuff. So they're really not fundamentally different. It's just the way it's given and how long it stays in your system. And there is more to say about Vivitrol and naloxone, et cetera, but that gets into a more complicated conversation. Can I say one other thing that while Barbara's still here that I really, it has really always bothered me? When you think of how the wording changes the way you think of something, I never think of treating diabetes in a way that has medication assistance. So when you say medication assisted treatment, it means like it looks like you got to get, it looks weird. So we treat diabetes with a medication. We treat heart disease with a medication. So we never say medication assisted heart failure treatment because we use medicine. So I think we should be talking about medication for substance use disorders, not medication assisted treatment, because it tends to throw it into this regulated world that you want to try to get out of. So just
No,
as a little
yeah, I
example.
completely agree, Jim. Oh, and one thing I just wanted to add too is we put in our work plan doing a case study look at your SPOT program. So one of the things that we'll be working with you on over the next year is to put together a focus on what that looks like, the data and outcomes that you have, so that we can promote that as a harm reduction model that other health centers can implement. So we're excited to put more spotlight on the SPOT program.
Oh, cool. Thank you.
No, I'm going to say one last thing if you don't ask me a question right now. The last thing I would, oh, there is a question, Valerie. Is that your hand from before or is that a new one? Oh. Here's where the struggle still exists and we need your help, okay? There are many, for example, we have a respite program and we admit people, we have 52 people on each floor, 2 floors, it's 104 people that come in. Many of those people are there because they need their heart failure taken care of. They've got cancer, they're on chemotherapy, you name it. There's many different things. And that many are also struggling with some substance use disorder and they're struggling with, with how to handle that. And what we found in situations like that, do you make the unit completely drug-free so that everybody knows that it's safe from drugs? Or do you allow those people who have a terrible illness, who are still struggling with their substance use disorder, to be able to use in some regulated way? Or, for example, go outside and use and come back in. And it brings huge battles among our staff and our other patients, where some patients want to feel very safe and not in a drug using world because that's a trigger for them. Other ones saying, I really need to get careful, but I just am not there yet. Can you take care of me still? So we struggle inside. That's an example of harm reduction where the communities are sort of clashing. And I don't know the right answer to that. I do know that our goal is to treat everybody and to do an individualized treatment. But if the treatment I have for you is threatening to the treatment for the patient next to you, it gets very tricky. Did I say that? I'd look to you guys to see if you've been in that same spot, but that's currently one of the really tricky things we're trying to grapple with.
Okay, Joanne, you want to go ahead and talk?
I see that Paul had
Paul had his hand up. Go ahead, Paul.
Oh, okay, Paul.
to Jim's inquiry.
Yeah, hi Jim. How you doing? It's good to see you. I haven't seen you in some years, but it's always good to see you. There was a time too in early recovery. I'm in recovery and been so for many, many years now. But in early recovery, I had worked with veterans, and I had this bias around methadone treatment, right? Because of course I am early in recovery, but then after being educated through this process of harm reduction and medication assisted treatment and seeing the positive outcomes that were happening with the veterans I was currently working with at that time was amazing. I did a 360 from this bias of, oh no, all they're doing is giving them this substance so they can continue to use while they're in treatment. However, watching that success while they're in treatment and doing methadone, the successes it was astonishing. I was like, oh my gosh, it worked, right? So I just wanted to just kind of throw that out there. And so if anybody on the call has this bias or early in recovery or has that type of bias about harm reduction and the drug that's being provided for those folks seeking recovery, it works. So.
Well, that was me. I didn't understand harm reduction, and I was so against the SPOT program. And Jim was saying it earlier, and then I fought it all the way. And then, one day we were losing people out in the streets left and right. People were just going behind buildings, getting high and just dropping dead behind them. And we find them 2 days later, whatever the case may be. And finally, the bell went off in my head, and I said, looked at Jesse, and I said, Jesse, I says, I guess we can't put dead people in detoxes. And what I realized that people were dropping dead, and yet we had no solution. So any solution was a good solution, or at least a hope, you know. And so we ended up going with you know, the SPOT program, and I worked in it for a while. And I learned and I watched, and I know that one guy overdosed, and I remember Barry, as some of you know, Barry came in and started saving his life, started hitting him with that, what's that stuff called? Like, my brain's gone. Up
Narcan.
in his Narcan. And after 3 times, the guy came out of it and he lived. Of course, he was deathly ill, but he made it through. But, you know, he saved somebody's life because of that program existed in our building. You know, so it's a little bit like what you were saying, Paul, you know, after seeing some things that work, you know, you gotta go along with it. I mean, you gotta say, wait a minute, there is something to this. You know, I know that we're in a dilemma now, Jim, with that, what the question you asked about upstairs. I don't know the answer to that. Maybe you could make one floor a little different and the other floor, you know, different. There's no right answer, wrong answer. I don't know the answer to that. I really don't. I don't know. I know that harm reduction is, for me, you know, it's just working with people, you know, not putting them down, not saying that you're junkie or calling them names and all these things that we used to tell people, you know, say no to drugs in the 60s, 70s, and the 80s and the 90s. You know, when people couldn't say no to drugs, they couldn't help but use. And those poor people are dead. Some of them are dead today because nobody would help them, or they couldn't be helped the way that that others could be helped because they couldn't say no to drugs, and they kept using until some of them are dead. Most are dead today. People like me are still here, which I don't know why, but I'm still here. So, I mean, you know, I'm grateful for harm reduction now, you know. And what is, Jim, what is that drug now, that new drug with the, they give horses or something? Didn't somebody just die of that today?
Oh, I didn't see, you know, there's a,
Somebody OD'd today and they thought it was that horse drug.
I think what you may mean is there's a sort of a medicine they give to horses called xylazine, which is now mixed with a lot of, it's mixed, it's what they mix opiates in every once in a while. And so you get a double whammy. You get the opioid coming in, and then you get this heavy sedation from xylazine, which means you've got both a sedative, which makes you want to, you know, makes you just not respond very well, and the opiate, which can put you to sort of asleep. And we're finding, I think in many cities, about half the supply of opiates right now is tainted with xylazine. It also causes terrible, if you inject it and it gets into the skin around you, you get these terrible infections that cause it. But that's the one that I think you're referring to, Joanne.
Yes, I am. And what about Narcan with that? Does Narcan, will it take you out of that with that stuff?
No. So that's one of the problems. So you can take a fentanyl mixed with xylazine, give the Narcan, and that'll reverse the fentanyl. But the xylazine has made you so sedated you don't wake up.
Oh, wow.
And so you've got to, and it doesn't respond to the Narcan. So you have to be very careful with that. And we're realizing it's causing us an awful lot of trouble. So more to just keep your eyes out for that. I don't know if you're seeing a lot of that in Baltimore, Barbara, but it's a big deal here in Boston right now. And I heard in Philadelphia it was a really big deal.
What is it again?
It's called xylazine. And you know what it is? It's an anesthetic. It's something they use when they want to put horses under to do operations on them. And it's a relative of a medicine some of you may know called clonidine.
Yep.
And clonidine is also used, you know, to help with sedation and stuff, but it's a very strong version of clonidine. And it also makes your
Ironic-
heart slow down, which is another problem.
Ironically, just today, the Council on the Medical Respite team did a webinar on xylazine, treating xylazine in medical respite settings. So we can always distribute the link to that, which I'm sure will have a lot more discussion about what this drug is doing and all of that, if you have more questions.
Okay, I'm seeing, hi guys, thank you so much for all this participation, back and forth, enthusiasm and interaction. But Warren has been waiting a very long time to say something, and also it's Myra, and it probably was directed toward a comment in time. So let's give first Warren and then Myra a chance to speak.
Sure.
Warren, you're muted.
Thank you. Hi, what's going on, people? Hi, Jim. Good to see you, man.
Nice to see you, Warren. So wonderful.
It's interesting that we're talking about a particular drug, or should I say, treatment to a drug that I've struggled for the last 25 years to get my mother off of. Very interesting. My mother used to go to the methadone clinic every morning over there by the police auction. And if anybody knows the city of Boston, and they had certain methadone clinic, one is right over there by the back end of Pine Street, under the bridge, off of Albany, I believe. And it's over there where they used to have the police cars auctions, right over there. And then they got another one over there by 1010 Mass Ave. So, I mean, over the years, Jim, I've fought for years to get my mother off of heroin and into a treatment program. By the time my mother turned 54, damn near on her deathbed, that was the only time they let her take methadone clinic home. And she was on dialysis. So, I mean, if anything, I understand your question about the advocacy part of it, because I've been fighting for years against heroin addicts and treatment, such as methadone clinics, for years. And I've been doing it since I became an adult. So you figure, I grew up in it, I watched my mother deal it, use it, and die from it. Basically it's all three phases of the game. So I mean, yeah, I got no problem advocating for you, Jim. You say the word and I'm there, bro.
Thanks, Warren. You're the best. I think we only got 5 minutes left. I see something up there, right? And then Myra had a question too, I guess. Love you, Warren.
Yes, I have a
Love
question.
you
I'm
too.
sorry.
All right.
So the first question was the list of drugs, but we probably don't have time for that. So maybe if somebody can send me a link, either via email or however, so I can understand that. And then my second question is, how do we get started with just doing the harm reduction in my clinic as a CAB member? Because we have a harm reduction center and they are amazing. They are advocating to get all these things done. But I want our clinic, because we have the people outside of our clinic using right there. So if somebody can send me a link of where to get started. Oh, thanks, Amanda. Great. Thanks.
All right. All right.
Joanne, if you would be so kind as to speak to us in the time that we have left regarding HIV.
Yeah, sure. Jim, I don't know if you want to hang around or you want to go. I know I kind of didn't make you. I didn't put a gun to your head. Kind of asked you to speak out of the clear blue tonight. You want to hang for the next 5 minutes, you can, or, you know, it's up to you, honey. I don't want
And
to.
I just wanted to make sure everybody knew that there was no way I could say no tonight. I'm thrilled to be here.
I
So
know.
thank you for asking. But I have to go put a 9-year-old to bed. So if you guys don't mind, I'm gonna go.
Oh, good luck.
But I know it takes a lot of reading, Warren, to get that done. But it's such a treat to see everyone, and thank you for what you're doing. Because the more I think about it, the more all of our programs are so much better because you're telling us what to do. So whatever you think on all this, I'll be anxious to hear. But Joanne, thanks for the invitation. Warren, great to see you, and Barbara and everyone else.
Always.
Valerie,
Yeah,
thank you. And
Jim,
well,
did you realize this is called the Ellen Dailey Advocacy Committee?
you know, I think I blanked out on that, but oh my God,
Yeah,
Ellen Dailey.
yeah,
We
but
won't
Ellen
hold it
Dailey-
against you.
Yeah, so I just wanted to share that with you.
No, thank you. We miss her terribly. But thanks, you guys. Have a great night, and I appreciate your welcoming me here. Take care now.
Best way to
Bye,
put him to
thank
sleep
you.
is NyQuil.
Thank you. No, Warren, Jesus. All right, so anyway, what was I gonna say? Yeah, I just want to share about one thing, I guess. I see Jim's dilemma as everyone else sees. I think what we gotta start doing is not like putting people down because they want to still get high. And we have to learn the conversation. We have to learn to be more understand, listen better, and not, you know, some people don't want to hear an answer. They just want you to listen. So I think we just need to listen more about what people really want and maybe guide them a little bit, but not put them down because they still want to do drugs. Because, you know, years ago so many people died because they couldn't stop, and they didn't have a harm reduction at that point. Harm
Right.
reduction, I believe, has saved a lot of people's lives. We just lost somebody today from I just heard, you know, because they want to go and do drugs behind a building, and they don't want to share it. And, you know, it's just so sad. And I think, you know, people shouldn't be afraid to come and talk to anybody about an issue that they have, whether it's with drugs or anything. That's why our building became like this, so that people can come to anybody in the building and people will have open arms for them, you know, just to show them that there's always love here, and we're not going to put you down for having a drug problem or a sex problem, any problem that you have. You know, we're here for you. And I know that we don't have much time here. It's 7 o'clock. As a matter of fact, we have no time. And I want to thank everybody for asking me to speak, even though I didn't say much. But
You
I
said
was
more
happy to
than
get,
enough.
thank you. I'm happy that I got Jim in here and to speak a little bit about those drugs that I don't know anything about. And Barbara, thank you. And Amanda, thank you. And thank you everybody for having me.
Joanne, it's
Yep.
Amy. And I just want to just
Hi, Amy.
mention, I remember those conversations you and I had when the SPOT program first started, and how you really struggled
Yeah.
Yeah.
with whether or not this was a good thing. And it took you a little bit of time, but you definitely saw the value in it. And I
Yeah.
love that you support it now, and it's a wonderful program. So
Yeah.
I can actually remember when the idea came up, and myself, Joanne, and members of our cab was sitting around the table brainstorming on stuff like this. This was a big, big topic, and to see it play itself out in reality is amazing to me.
Yeah. Yeah. You know, Barbara, I'd like you to send me that thing from the respite if you could. You know, I'm invited to their meeting all the time. I just don't go. I think I wish I went to hear about that drug that they're talking about. You know, I don't know enough about them, but you know, now that I'm back live in awake and aware of what's going on around me, I want to start being back in action. So it's 7 o'clock. We all have to go, right?
You know what, Joanne? I can always put you on my chair and we can go piggybacking.
Yeah.
I thought it was till 7:30. That's what I had put the notices for, so.
Oh, okay.
We'll have to check with Cindy.
No, it's actually ends at the top of the hour. Sorry. Sometimes the advocacy committee meetings are longer, but this session is just an hour. So I'm sorry about that. We will
Okay.
have to kind of wind it down.